Oh, Courtney, will you please monitor the chat function?
Yes, absolutely.
Thank you. Kesh, do we usually take questions at the end
Yes.
rather than during?
Yeah.
Okay.
Yeah.
Thank you.
Yeah. But I'll also monitor the questions. You can, Courtney, if you can keep an eye as well, that'll be good.
Definitely.
Thank you.
So, hi everyone, this is Courtney Spitzer, the project coordinator for our Early Psychosis Learning Collaborative. Please feel free to introduce yourself in the chat box. Now, I just want to review a few housekeeping items before we begin. Go to the next slide, please. Participant microphones have been muted at entry, and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat box. This webinar is being recorded and will be available for viewing at a later time on the MHTTC website. To reach us after the webinar, you can email newengland@mhttcnetwork.org. This slide provides a description of our disclaimers for MHTTC. And next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of our diverse cultures, genders, perspectives, and experiences, healing-centered, trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, consistent with our actions, policies, and products. With that, it's my pleasure to hand it over to Dr. Machiri Keshavan for introductions.
Thank you, Courtney, and good afternoon, everyone. It's my pleasure to introduce Dr. Lawrence Yang, who is Vice Chair and Associate Professor of Psychiatry at the New York University. He also wears several hats, including the founding director for Global Mental Health and Stigma program, as well as a associate director of the Global Center for Implementation Sciences, both at the New York University's Social and Behavioral Sciences Department. I won't go into a lot of details about Larry, who for several years. He is not new to where we are hosting this seminar from, which is Massachusetts Mental Health Center, where he did some of his training. Dr. Yang has been a pioneer in the field of understanding early course psychosis and schizophrenia and cognition, and the issues of stigma as they impact serious mental illness. In fact, the initial mission statement that you read about MHTTC of the need to use recovery-oriented language and inclusiveness, they are all central to what he's going to be speaking on. Briefly, Dr. Yang's contributions has widely ranged between understanding the natural course of schizophrenia in terms of the cognitive impairments in this illness, in which I am fortunate to be collaborating with him. His really seminal studies in China, but also another seminal line of work that he has been pursuing through NIH funding is to understand the nature of stigma and the importance of how we communicate the nature of illness with young people who have those. The talk today he's going to give us is in many ways very important to all of us in the field of mental health, and that is how to discuss symptoms in the context of high risk for psychosis as they are emerging in the early course of these illnesses, and how that can help us develop the best alliance and engagement with the patients that we serve. So without much further ado, Larry, you have the podium. Thank you.
Thank you so much, Kesh.
Yeah.
First of all, for this incredible invitation and opportunity to return virtually to Mass Mental. I wish I could be there in person. So today I'm going to be talking about the early psychosis risk designation. And I'll be talking about, is stigma associated with symptoms or the at-risk identification? This is work that is supported by an NIMH R01 that's been completed and is now continuing through another R21 through NHGRI. So let me just say a little bit about myself because I'm meeting many of you for the first time. So I have been in the field of looking at social factors that influence course of schizophrenia for quite some time. My training is interdisciplinary, and you'll see some of that today. PhD in clinical psychology, but strong training in anthropology and psychiatric epidemiology. And as Dr. Keshavan noted, I did my clinical fellowship at Mass Mental. I actually was in the old Mass Mental building and in the basement with all the rest of my fellow clinical interns. And, it was a seminal and really transformative part of my training that I've carried into my work today. In terms of NIH funding, I've just been very fortunate to have a set of awards. An R01 around stigma of CHR that I'll be talking about today. Another R21 around stigma of genetic attributions in prodromal psychosis. And then currently 3 R01s, 2 in the cognition of untreated psychosis in China, which Dr. Keshavan is an MPI on, and another R01 on task sharing in global mental health. And last year, just because of this work, just again, very fortunate. I really consider this to be really representing the entire team that I received the Mulch Prize for Innovative and Promising Schizophrenia Research. And so, very grateful to the BBRF for their support. So today's talk, I'm going to, it's broken up into 2 main sections. The first section is what I call a primer on stigma. I just want to make sure that we're all on the same page. Stigma is a very a complex concept, and so I'm going to give some signposts for us to move forward with. I'm going to talk about the main concepts of public stigma, experience discrimination, and self-stigma. And I'll spend some time on self-stigma, and then structural stigma. And then I will then go into the main part of my talk, which is around stigma and CHR. And I will talk about new quantitative findings from the R01. These are actually the first time I will be presenting these findings. I consider them to be near final. We're really excited to get them out into the world. I will also talk about another smaller qualitative study and then end, as Dr. Keshavan talked about, with clinical implications for the field. So to start with the stigma primer. The stigma, first of all, we can understand it to be a set of interrelated social processes. This was written about by my mentors, Bruce Lincoln and Joe Phelan in 2001. In brief, there are 6 different dimensions of stigma. It consists of labeling, so basically identifying the stigmatizing behavior or action, stereotyping, these actions or manifestations, cognitive separation of us from them, so them regrettably being the people who have the stigmatized status, emotional reactions, so this can range from anywhere from fear to pity, status loss and discrimination, because usually the stigmatized group is discriminated against, and then power, because the stigmatized group typically is in a position of less power than the mainstream group. And so stigma, when it occurs via these interrelated social processes, then leads to poor symptomatic and social outcomes. So the first main concept of stigma is that of public stigma. And so this is the process in which the general public stigmatizes individuals with mental illness, which consists of processes of stereotyping, prejudice, and discrimination. So we can think of this as the community conceptions or stereotypes of stigma that exist in the world. The second form of stigma we can understand as experience discrimination. So this is when an individual is unfairly treated by another individual based on their status of having a mental illness or mental health condition. And so this is what we traditionally think of in terms of stigma when people are treated badly by other people. The third form of stigma is internalized stigma. So this takes place through stigmatized individuals themselves once they become aware of stereotypes and apply stereotypes to themselves. So I want to this point is very important. Nobody has to actually treat a person negatively in order for negative consequences to unfold when stigma acts through this route. So I'll illustrate this following slide. So this is one of the most prominent frameworks of internalized stigma that was formulated again by Bruce Link in 1989 and is hugely influential in the field. So it's called modified labeling theory, but let me walk you through it like a story, as I like to tell this. So in step one, we have societal conceptions of what it means to have a mental illness. In this case, let's use psychosis as the example, apropos of the talk. And so people have we've all grew up in US society, different sectors of US society, or many of us, I should say, grew up in US society. And there are just stereotypes that are associated with people with psychosis. These are all regrettable and unfortunate stereotypes that we need to, combat really on every single level. But, to date, they consist of things like dangerous, unpredictable, may not contribute to society in a meaningful way. And again, regrettable, unfortunate stereotypes, but these are commonly held by the groups that we grow up in. Let's go down to the bottom pathway. So let's say you never have experiences, symptoms or experiences of psychosis. And so you're never given what's called, an official quote unquote diagnosis or label. And so you're aware of these societal conceptions, but well, you know they exist, but you're never labeled. So these are irrelevant to who you are. So there are no consequences due to labeling. Let's now go the other pathway. Let's say that you start to see or hear things that other people don't, experience, and or you have fixed false beliefs or delusions. And then you come into contact with psychiatric services. And at that point, you actually are given a diagnosis of a psychotic disorder, schizophrenia, let's say. At this point, this is when all these conceptions of psychosis then become relevant to who you are. Let me pause here actually just for one moment, because of course, official diagnosis also triggers a whole host of positive things. It can trigger relief on the participant's part. It can also trigger, of course, accurate treatment, and then signal a better course of recovery. So all of these things happen together. However, parallel to all these positive components, we do have these potentially negative social processes that we should be aware of and do our best to really try to mitigate. So if a person, again, is diagnosed with, let's say, psychotic disorder, all of a sudden these concepts that you're aware of, dangerous, unpredictable, may not be able to contribute meaningfully to society, these things all of a sudden become relevant to who you are. And so because of these conceptions in the world, you may not choose to be so forthcoming with this information to people in your social network. So for instance, you might become more secretive or withdraw from your social group. So you might not go to socialize with your friends like you had planned on Friday night, or you might not go for that job or start school in a way that you had planned before. So if you do, endorse one of these more harmful coping strategies, then these could lead to negative consequences for self-esteem, earning power, your social network. And this constellation of negative social consequences could then lead to vulnerability to another episode of illness or repeat episode. What's also very helpful about the modified labeling theory model is that it gives us a good spots where we can actually intervene with stigma. So of course, we should continue to intervene on the societal level. It's slow work, but it must be done. And we've seen changes over the decades. Another space that we could see an area for intervention could be when the person is labeled or communicated the diagnosis. This would be another prime point. And then lastly, how they cope or respond to the diagnosis is also another crucial point. So this slide just shows from a meta-analysis widely cited in 2010 that internalized stigma, these are all forms of internalized stigma on the left side, are associated with a host of negative psychosocial outcomes. This includes self-esteem, quality of life, depressive symptoms, treatment adherence, and social support. Okay, so that was the bit on internalized stigma. And so the last part here is around structural stigma. I just should note it, that this form of stigma is when institutional practices work to the disadvantage to the stigmatized group or person. This can be laws and policies, etc. All right. So that wraps up my primer around stigma. Pretty short, but I just wanted to make sure we're all on the same page as we talk about this, relative, pretty complex concept. So now on to part two, the main part of my talk, where I'm going to be speaking about stigma and the clinical high-risk state for psychosis. I'm sure many of you are aware of this identification state, relatively new. I'm going to abbreviate it CHR throughout today's talk. It's a category to identify youth, 12 to 25 years typically, who may in the future develop psychosis. It's the earliest identification of pre-psychotic signs. Approximately 29% transition to a full psychotic disorder within 2 years. So when, for a while now, as this identification state has really proliferated everywhere, and especially in the US, there has been a particular concern around stigma that may be associated with this identification. And this has been written about by Will Carpenter, myself in 2010, because over 70% of these youth will actually not go on to develop a psychotic disorder. So they're being given an identification state that, may add or trigger new stigma. And so the field in the writings has really grappled with, or I should say, really emphasized this issue, that the possibility of that youth are being told this new, again, at-risk state, this new quote unquote label from stigma thinking, what could happen? Could this lead to negative consequences? What we've seen in the interim are a host of studies from public stigma to self-stigma showing that the stigma that's present for CHR is associated with negative psychosocial outcomes. This also includes impacts on help seeking and service contact per 2017 review. Okay, so I'm gonna pick this theme up in just a little bit, okay, sort of the overarching, stigma, the risks that stigma poses to the field and how our study is going to really try to come in and answer a central piece of this question. But let me take you on a little bit of a sidebar here. So our group, our R01 research group, has really just done a tremendous, in my mind, a tremendous job looking at this issue from different perspectives. And so I'm going to refer to these as precursor studies. So we have a precursor study A and a precursor study B. And I'm just going to do this little segue because it's going to inform actually the main study findings I'm going to present to you in a little bit. So one of the first things that we did actually in this 3-site cohort, which I'll describe in more detail, was to examine what youth endorsed as being most impacted by their sense of self. What was it most affected by when they first walked into the CHR services? And a lot of these youth hadn't actually been told they were CHR yet. We just wanted to know naturalistically what they were most concerned about with. And what were youth most concerned with psychosis or schizophrenia versus other non-psychotic disorders, which they commonly experience, depression, anxiety, etc. And so just jumping to the main finding, one of the main findings from precursor study A, this was published. And actually, I should really thank you, Dr. Keshavan, for his support via Schizophrenia Research, the excellent journal that he is editor of. 2019, we published that actually, and somewhat counterintuitively, youth actually, almost 70% of youth in this 3-site study, and of 148, were most impacted, their sense of self were most impacted by non-psychotic disorders, so depression and anxiety versus psychosis or schizophrenia, where there was still a substantial minority, about 28%. But this is a somewhat counterintuitive finding that actually illustrated that, okay, well, maybe actually, youth, because they've been experiencing depression and anxiety for so long before a lot of them, before they walk in the door or ADHD, this might be actually more impacting to the sense of self than what we've been most concerned about, which is, the psychosis and psychosis. Let me jump to a precursor study B that our group also did. So what is the emotional impact of identification? So this study was one of the only studies that I'm aware of that assessed changes in emotions pre and then post CHR clinical feedback. So what was really great about this study was that basically we assessed stigma right before youth were told that they're at CHR risk, and then we gave the same instrument right afterwards. And so this study was led by my really close colleague, Kristen Woodbury, published again in Schizophrenia Research 2021. And what we could see here at the 54 youth who were, we were able to interview in this way. What you can see here, the red are the negative emotions, blue are the positive emotions. The solid bars are pre, the striped bars are post. What we can see here is a pretty nifty finding that youth, right after being told they're at CHR risk, actually felt less embarrassed, different, angry, ashamed, sad, and worried. And these are almost all significant. So pretty strong signal that CHR feedback actually leads to reduction in negative emotions. And that's a very optimistic finding for the field. I also should note that, unfortunately, we didn't see a corresponding increase in the positive emotion. So youth did not feel any more hopeful, relieved, or empowered. But so be it. Those are things that we can work on for the future. So let me bring you back. So I'll refer to these studies later on as I go through the presentation, these precursor studies A and B. But returning back to this main issue of stigma, CHR, one of the big risks for the overall field. One of the big limitations of the prior set of studies that I had shown you in a couple slides ago is that they weren't able to differentiate different sources of stigma. They just asked about mental illness stigma generally. And so, and there are two sources of stigma that I believe we should be particularly concerned with. So it's stigma of the at-risk identification state itself, or what I call the label, versus stigma that's associated with the symptomatology or the experiences that the youth bring in as they come into the CHR identification state. And I'm going to describe to you in detail what these things are. But the ramifications for the field, we believe, are quite profound. So as you all are probably aware, CHR youth are identified when they are help-seeking and active, and have worsening symptoms and experiences. And so the whole premise of CHR treatment is really to identify and treat symptoms at its earliest stage and to really mitigate those symptoms from becoming more severe psychotic symptoms. And so because CHR is oriented this way, this could also avert significant stigma that would be associated with increasing symptoms. This includes things like psychiatric hospitalization and schizophrenia diagnosis. So if symptom-related stigma at identification is a primary correlate, then, we might be somewhat less concerned with this form of stigma because it's really consistent with the earliest identification methods to find people when their symptoms are just starting and to try to keep those symptoms from increasing. The second form of stigma, though, could be more concerning. And again, the field has really focused more on this in terms of the debate. And this is around the stigma of telling the youth or communicating to them, or what we call labeling stigma, because this is a new, quote unquote, new source of stigma that the youth would experience, right? That the field is basically potentially communicating to them. If the CHR identification state didn't exist, then the youth wouldn't have this new experience. So labeling related stigma we could consider this to be particularly concerning to the field because it's an added experience that the youth face. But then also, this could also shape potential inclusion of the CHR in future diagnostic systems. And this is actually a debate that the study today I want to seeks to address. So in 2015, we developed a measure of stigma that actually was designed directly to address this issue. And again, published Schizophrenia Research 2015. And this measure of stigma assesses 3 domains of stigma, and I have them listed here. It's shame, secrecy, and discrimination. And what we do here for the labeling version of the stigma items, the referent is about being told I'm at risk for developing psychosis. So here, all the stigma questions are oriented, right, towards what the youth responds to in terms of having been told that they're at risk for psychosis. So the item, for instance, for shame goes about being told I'm at risk for developing psychosis, I felt shame. Secrecy, I've told no one that I'm at risk for developing psychosis. And discrimination, about being told I'm at risk for developing psychosis, people are a little afraid of me. So again, we're really able to isolate CHR stigma associated with this identification. We then ask a corresponding set of items that are associated with symptoms and experiences associated, again, with these different stigma domains. So again, we ask the exact same stigma questions, but this time we gear it towards the respondent's symptoms and experiences. So I'll read you through the items. About my symptoms and experiences, I have felt ashamed. I have told no one about my symptoms and experiences. About my symptoms and experiences, people are a little afraid of me. So through this way, we're actually able to do a head-to-head comparison between labeling-related and symptom-related stigma. Another important background note here is that in terms of CHR communication, there is to date no consensus on a standardized way of communicating the CHR status for all participants in CHR programs. And right now, specialized CHR program clinicians are typically trained to give individualized feedback based on a wide variety of factors. This includes individual and family's concerns, treatment engagement, cultural background, and estimated risk within the CHR classification. There's also an appropriate, to this earliest identification effort, there's an increasing emphasis on a recovery orientation and mitigating the functional deficits accompanying CHR, whether or not the youth actually progresses on to developing a psychotic disorder. All right, so our main study hypotheses today. We have two main hypotheses, and to address this large issue in the field around labeling versus symptom-related stigma, which is more salient. So the first hypothesis is comparing labeling versus symptom-related stigma head-to-head, which is higher. Number two is assessing to what extent labeling versus symptom stigma is associated with psychological and social outcomes in CHR youth. And so this includes self-esteem, quality of life, social function, and social networks. Our sample is 169 CHR youth. They were given a stigma assessment at CHR identification, so typically within a month or two, but typically within a month, and then 6-month follow-up at Harvard, Maine, and Columbia. So it was a 3-site study. We collected data over a 5-year period. So this was a lengthy effort a lot of people contributed to. Today, I will be presenting the baseline data only. Again, these data are near final, and we're really excited to get them out to the rest of the field. You're going to be hearing about them for the first time today. And these individuals met official COPS criteria. These are help-seeking participants who met one or more CPSOPS criteria. These are the three standard CPSOPS criteria for CHR. The vast majority of youth in our study met the first attenuated positive symptom syndrome, which is typical of CHR cohorts. I do want to note, very important note here. So, and this refers back to precursor study A, because not all youth who come into the service, right, believe that they're at risk, most impacted by psychosis risk, or even at all impacted by psychosis risk. And so for this particular study, we only included CHR individuals who perceived at least some amount of psychosis risk. And so we excluded the youth. There's about 20 to 25%, very interesting group. We'll look at them another time, who actually don't, even though they meet criteria for CHR, they don't actually endorse any amount of psychosis risk. So that's a very interesting, and we consider them to be a somewhat atypical group. Because we were looking at labeling stigma versus symptom stigma, it didn't really make sense to include this group because they didn't believe that the CHR label applied to them. So we excluded this group for our analysis. In terms of the participants, we ended up with 113 respondents who had complete stigma data. And let me just give you a snapshot of who they are, of what they look like, 18 years on average, 12 years of education, moderate to modest levels of positive, negative, disorganized, and general symptoms, moderately impaired via the GAF, majority male, a range from the 3 different recruitment sites, primarily US speaking, born in the US and English speaking, range of incomes. Of note here, to pause here for a second, many of the youth were comorbid at identification with another non-psychotic axis 1 disorder. This includes depression, anxiety, and ADHD, about 2/3, at least 2/3. Most were not married, and most of them were actually students, 82%, and majority white. So the outcomes include We have psychological outcomes. We utilized the Rosenberg self-esteem scale, widely used. We also utilized the WHO quality of life scale. This was, to our knowledge, one of the first usages of it in CHR. So we did a factor analysis to look how does it apply or how does it break out among youth at CHR. And we came up with derived these four factors: depressive symptoms and functioning, enjoyment with life and personal relationships, satisfaction with environment, and satisfaction with overall health. And so I'll be reporting on these four factors. For the social outcomes, this includes the global functioning social scale. This is Kornblatt's widely used 1 to 10 rating. And then we had a loss of social networks. And what this was loss of relationships or support due to stigma. And this was 3 items that we combined from the Norbeck Social Support Questionnaire. All right, so I'm going to jump right into the main findings. Hypothesis 1, we're going to compare head-to-head, which is higher, labeling related or symptom-related stigma. And so we looked at 3 different stigma domains: shame, secrecy, and discrimination. And what you can see here is that the findings are mixed. What you can see here is that symptom-related shame is higher than labeling-related shame. It is significant, but we see the reverse happening in secrecy. Labeling-related secrecy is actually significantly higher than labeling-related symptoms. So youth are more secretive about the highrisk identification state than their symptoms of it. Discrimination is actually no differences. So right now we have basically mixed findings for hypothesis 1. Let me jump into hypothesis 2. And here what we're doing is we're comparing head-to-head labeling stigma, symptom-related stigma, and their association with the different psychosocial outcomes. This slide is quite busy. So what I'm going to do is I'm going to walk you through one model in detail and then zoom back out and take a look at the big picture. So, but let me orient you to the slide first. This is 3 out of the 4 psychosocial outcomes. It includes self-esteem, social support loss, and social function. So those are 3 out of the 4 main outcomes. We then have 3 domains of stigma. We have shame, secrecy, and discrimination. These are the 3 we're looking at. In each domain of stigma, we have labeling versus symptom sources. So you can see here, each one is broken up into a labeling versus symptom. So let me walk you through this first model here, looking at shame's associations with self-esteem. And what we can see here, what we have here is what we called a combined effects model, model 3. There is a model 1 and 2, but I'm not showing those. Too much data and not relevant, not particularly relevant. So what we did here in model 3 is we compared head-to-head. We put in the regression model, labeling related sources of stigma versus symptom related sources of stigma. And we picked them, basically made them compete with one another. And if there was one correlate that emerged, as a significant correlate over the other, that's what we were looking for in model 3. And here you could see, for instance, for shame, we have symptom-related shame is actually significantly associated, bolded here, with self-esteem, whereas the labeling version of shame is not. So we then took the winner, quote unquote, from model 3 and advanced it to model 4. And we then put this by itself into the regression model, but this time entered in, this time entered in a host of covariates of interest. So this includes site, age, sex, race, total positive, negative, and disorganized symptoms. Because we wanted to see, okay, well, let's account for all these other covariates and see whether or not the winner, quote unquote, in this case, symptom-related stigma, still is associated with the outcome of self-esteem. And in this case, it is. Anything that emerges as a bolded and in color finding is actually emerges as a, as a final correlate, so to speak, even after accounting for the other version of stigma and this host of covariates. Okay, but let's zoom back out. I'll walk you through one of the models. Each one of these models is the same. What you can see here is that for self-esteem, we have one symptom-related shame is associated. Same thing, labeling-related discrimination. I put labeling in green, I put symptom in red, easier on the eye. For social support loss, you can see that symptom shame, symptom discrimination in this case, associated social support loss. For social function, in this case, it's labeling-related secrecy. So it's a mix of findings. If we return to our major debate, which one of these forms of stigma is more salient, it looks pretty mixed at this point. Let's go on to the last outcome, quality of life. So quality of life, as you recall, has 4 factors, and these are listed up top here. I'm going to draw our attention to the associations, the significant associations that we see in model 4. After accounting for the other form of stigma and all the different covariates, you can see here out of the 6 significant associations that emerge, all of them are related to symptom-related stigma. So interestingly here, you can see when looking at the quality of life outcomes, this is where the story really starts to shift much more towards symptom-related stigma, as opposed to labeling-related stigma being the bigger issue at earliest identification. So let's take a look at this summary slide that will enable us to kind of glean some patterns from these overall set of findings. So again here, just to orient you, we have all of the different outcomes. The WHO factors are all the quality of life factors, 1, 2, 3, 4. And then these are the 3 different other outcomes. And then we have shame, secrecy, and discrimination, and then the different sorts of other. What you can see here, I listed all of the significant associations. There are 11 of them. And what you see is mostly red. So what that means is that symptom-related stigma, when stigma is an issue, it's predominantly really symptom-related stigma. So that's a very interesting and new finding for the field. Now, a couple of the things I'll point out. Symptom-related stigma overall appears to be the issue, the bigger issue, I should say. But the thing is that within symptom-related stigma, it's really shame and discrimination. You can see is doing the lion's share of the associations. In symptom-related secrecy, I'll put out one other thing. This is very interesting. All of the other stigma findings act in the way that you would think. If there's higher stigma, whatever form it is, you have a worse psychosocial outcome. There's one exception. The one exception is around secrecy related to people's symptoms. This is a very interesting finding, and if it replicates, holds up, what it says is that if youth are secretive about their symptoms, it's actually protective. It's actually protective of their overall satisfaction of their health. So it appears that, and this is actually consistent with modified labeling theory, for instance. It's secrecy. Well, actually, secrecy really has a double-edged sword. On the one hand, too much secrecy leads to negative outcomes. On the other hand, it can be protective as well in certain circumstances. So I'll return to this finding later in the implications. All right, so now I'm going to shift over to a qualitative study that I think will give flesh out sort of the meat on the bone, so to speak. This was a study where we did examining the nature of labeling-related stigma related to the subjective experience of being told that you're at CHR. And this was done with a prior pilot study. I'll get into the sampling in a little bit. But we wanted to qualitatively examine the processes, really give some nuance to some of the findings, to look at positive effects. So how, for instance, direct interaction with specialized CHR clinicians. This, of course, happens when you're identified as at CHR. Also, there are, of course, potential negative effects, as we've described, anticipated stigma operating through CHR individuals themselves. Importantly, we wanted to look at the co-occurrence of these 2 things. Other studies have looked at one or the other, but not necessarily at how they overlap. So we did this study as a precursor to the R01 study. This was in 2009 to 2010. There were 38 youth at CHR where we examined the meaning of being told that they are at CHR. And so I do want to note this sample is different than our R01 sample, which again which I described to you, really is at first identification, within a month or 2. These youth were anywhere from 0 months to 3 years in the CHR service. On average, they're 11.5 months in the service with a big standard deviation. So it's youth who could have been there for a long time or who are very new. All the same, I believe that the findings yield a pretty important point. So the qual questions include one around experience discrimination, so direct treatment from others related to the CHR identification. Here's the question. Is there anything that happened to you in terms of how people treated you, good or bad, as a result of being in the CHR program? Probes include, can you give me an example? Who treated you this way? How did it make you feel? How did you respond? Second question is around internalized processes. So here we asked, in relation to the CHR identification. So here we asked, in being in this program, you were told you have an increased risk of psychosis compared to your peers. How has this affected how you see yourself and how others see you? Some probes. Did being told you are at risk for psychosis change the way you thought about yourself? So how? Second, are you concerned about how others might react to knowing your at-risk status? Would others treat you any differently? So this question was around internalized stigma. Okay, and the qualitative analysis we used was through in vivo. There was a significant methodological advantage. We could quantify the overlap between major codes. And we wanted to look at the intersection between positive and negative labeling experiences. And this is nifty metric that in vivo gives us. It's called Jacquard's Similarity Index, or the J index. But in a nutshell, you can just, it basically gives you the percentage of overlap between different codes, 0 to 100%. And this features prominently. All right, so let me walk you through the 4 most common positive themes that emerged from these transcripts. And again, this is around youth being told they're at risk for CHR. You can see here that J here is Jacquard's coefficient. 93% of transcripts had at least one positive instance of ramification of being told they're at CHR. And so here they endorse the positive experience of being identified as CHR, and then we have, these are examples or example quotes from respondents. So the first most frequent positive experience, accurate understanding of CHR at risk, 59% of transcripts. Here, the respondents demonstrated a correct understanding of what it means to have CHR status about specific language, using specific language about risk. Quote, it's being identified as CHR like having a sore throat. You don't have to, hold on a second, hold on. Sorry about that. I need to be able to see the screen. Okay. You don't know that it will lead to strep throat. You have something indicating something is wrong, but it might not develop into strep throat. The second most common positive theme, interpersonal benefits of disclosure, 50% of transcripts. Disclosure of CHR identification leads to more supportive relationships. Quote, other people, friends and family are more aware of what I'm thinking and feeling because of my CHR status. It is something like they are more sensitive to me about. They are more supportive. Third most common theme, benefits of specialized CHR treatment, 33% of transcripts. Endorsing more tailored treatment due to receiving specialized CHR services through psychosis risk identification. Quote, treatment at COPE, which is the CHR program at Columbia, has been absolutely amazing. Talking to my therapist, reading different studies, I can think about my symptoms and feelings in a different way. Fourth most common example, explanation and legitimization of symptoms. So 25% of transcripts being identified as a CHR explains and or legitimizes previous experiences and symptoms. So cool. I sometimes use coming to COPE as a way to convey the severity of my problems. I have an illness with symptoms that's being treated medically, and that is, my symptoms are legitimate. And she's saying this in response to a coworker's delegitimizing reaction. So again, these are most common positive benefits that happen as a result of that designation. Let's take a look at the 4 most common negative themes that emerged. This was interesting, common, but not as common as the positive themes. 62% of transcripts endorsed 1 or more negative experiences from being identified as a CHR, and it reflects 1 or more of these below code categories. The most common, interestingly for stigma, is actually shame and internalized stigma. So 55% of respondents, the CHR label induces shame and internalized stigma due to stereotypes of psychosis. Quote, when I first came to COPE, I had some feelings of embarrassment and shame when talking to friends about coming to NYC. I wouldn't tell others I was there to visit COPE. There's a stigma with mental illness. Schizophrenia is a conversation stopper. Second most negative example, perceived exacerbation of CHR experiences, 41% of transcripts. Here, there's an over-monitoring of CHR symptoms and interpreting them as signs of full psychosis after psychosis identification. So, quote, I've become one with the symptoms I've read about. I'm constantly on the lookout to see if I have schizophrenia. I've looked so much into my symptoms of schizophrenia, it's fueled the perception disturbances that I've had. Third most common, interestingly, negative theme, structural discrimination, 27% of transcripts. fears of being treated differently by institutions due to identification, the whole notion that I might have schizophrenia someday. Will I be able to achieve certain things I set out to do? Government rules for security clearance are based on mental stability. The fact I was once on antipsychotic drugs is on my record forever. Even if I successfully recover, and hypothetically, when I get a job in the government, it would still be on my record. This was actually a college student respondent. It was quite plausible this could have happened in the future. Fourth most common negative theme, anticipated stigma and discrimination. 22% of transcripts expecting that people will think about or treat you differently due to identification. Quote, if I tell them I'm at risk for psychosis, they may think of me as a mental patient, that I'm dangerous, they shouldn't be around me, they're afraid of me. Okay, so I think those findings are interesting in themselves, but where this set of findings I think really pulls for, advances our understanding is really in their co-occurrence. Positive and negative themes actually co-occurred on over 50% of transcripts, and the actual percentage is 55%, which signifies that it's not just positive effects happen by themselves or negative effects, but really the two of them happen in the same breath. And I want to give you two of the most common overlaps to give you a sense of how this might occur. So here you could see that youth benefit in terms of interpersonal benefits of disclosure, but then at the same time, people think of them differently or treat them negatively. So here in blue, we have the positive, and red, we have the negative. And so here's a quote. To talk about my at-risk status, there was stigma I had. Having this new status, being identified as CHR, also scared my mom as well. So mom sees her differently, negative. My mom is a sister with schizophrenia. Being identified as at risk equals people thinking you're really developing something. I sometimes use coming to cope as a way to convey the severity of my problems. People try to be supportive. People make extra efforts. They would check in on me more. So at the same time, or the next breath, people are also acting in a more supportive way. So both are occurring basically, at the same time. Second most common overlapping example, there's an accurate understanding of risk status, and this co-occurs with perceived exacerbation of experiences themselves, 40%. So, so again, blue is positive. They have a better understanding of being at risk. But on the other hand, it leads to an increased anxiety. This is in red. So the quote, I now know that being CHR conveys a slightly greater risk for disease. Shows accurate understanding. But it's a very complicated concept to explain to people. Dr. Kelly, the program psychiatrist, tells me about perceptual difficulties. I worry that these might be signs of psychosis. First identification, I was more worried because I thought it meant I was psychotic, and there was an increase in the possibility that psychosis was really happening. So here again, you could see that both the positive and negative effects are occurring, basically at the same time. All right. So I'll walk you through a set of findings. Let's talk about, let's merge with some takeaways. So the discussion, the main findings for the quantitative. I want to return to this overarching question that, facing the CHR field. And this is concerns about additive or labeling related stigma that the identification state could contribute to youth. So our first hypothesis, we wanted to compare head to head which form of stigma is higher. The findings are mixed. Symptom shame is higher. However, labeling secrecy is also higher. So it's basically even for hypothesis 1. However, in hypothesis 2, which form of stigma is more strongly associated? This is really where we see the significant associations. Among the 11 significant associations of outcomes, 9 have symptom stigma as a stronger correlate. And this really emerges among quality of life. So this is, I believe, really signifies, the best data to date that says that stigma is an issue, but stigma does matter for CHR. But the lion's share of it is really being driven by symptom-related stigma. This is more salient at baseline. And in a sense, we might, as a field, be somewhat less concerned with this type of stigma simply because the services are oriented towards catching symptoms as quickly as possible and reducing them. There is a caveat, and I think the caveat is actually pretty important. So youth, again, as I had noted earlier, about 2/3 of respondents are comorbid for at least one non-psychotic disorder, actually probably more. So we don't actually know whether or not the symptom-related stigma, unfortunately, the way the question's worded, we're not sure whether it's geared towards the psychosis symptoms or towards the non-psychotic disorders that are present. A lot of times, prior to the CHR identification. And I'll say more on this in just a little bit. It just raises the question of, which form of symptom stigma is where is the stigma being attached to? But regardless, what our findings also show is that symptom-related stigma should be a target for CHR treatment. And I'll get into this in just a little bit. It really shows quite strongly that, stigma is an issue, and it's this particular form of stigma that is an issue. Also, labeling stigma is present. It's not to say that it's not relevant. It is there. And also, a very important caveat is that these youth have just been told they're, at CHR. So maybe there's been no time to really associate stigma with this quote-unquote label. Labeling-related stigma could grow as youth become more familiar with their identification status and people have a chance to, react to it. In terms of the qualitative findings, being told that one is at risk for psychosis is most likely linked with positive and negative experiences, which commonly overlap. And so I think the take home here is that we want to minimize the negative effects while accentuating the positive effects. These don't occur in isolation, and that just to really think about it and consider it from a sophisticated clinical lens. So in terms of specific implications for clinical care, this is my wrap up. For labeling related stigma, I think this whole set of findings, we can walk away with some recommendations. And a lot of it's honestly to continue what's already been happening. So clinical feedback about being at CHR can reduce stress, so shame, alienation, and anxiety. And this has been shown in Kristen's publication in 2021. But eliciting what this means to an individual is essential to addressing internalized. This is precursor study B. From precursor study A, which showed that, more folks were more concerned about non-psychiatric disorders when they first came to the CHR program. Specialized CHR programs could be careful to avoid a singular focus on psychosis risk and attend to what is most distressing to each individual. So, for instance, non-psychotic disorders and functional impairment. And then labeling-related stigma may be mitigated via open and thoughtful communication. This includes eliciting individuals' language and understanding to allow for non-diagnostic and person-centered terminology while accurately conveying the at-risk status. To also, second, to directly probe how the individual perceives the impact of their status on the sense of self and perceptions of others to open up avenues for resilience. Third, to connect them to people living well with CHR to help address internalized stigma. Of course, peer involvement is really essential. It's one of the primary ways to really fend off stigma of any mental health condition. And then lastly, to focus on resources available to help with individualized goal attainment. So I think the field has thought about how to address and mitigate labeling related stigma. And so it's a matter of emphasizing and just bringing these to the fore, even more so as we proceed. What's new, though, for our findings are really the implications around symptom-related stigma for clinical care. And so our findings really indicate that symptom-related stigma could be a new target for CHR treatment, and that this should be routinely assessed. So again, shame and discrimination related to symptoms. And that it's possible that the stigma may be associated with the psychotic features, but it's also quite possible it may be related to the non-psychotic mental health symptoms, which may precede the CHR identification by several years. And again, our findings really raise the importance of one or both. This last thought is actually not directly from the results, but more from the clinical wisdom of our team. And please just follow me on this. So symptom-related stigma, it has to be noticed by people in the social world. So it has to be noticed and then interpreted. And so there's probably what's going on is some informal labeling of what's, the symptoms that are occurring or have occurred. And so there may be informal labeling. Again, these really regrettable informal labels of, for instance, weirdo. This could lead to social withdrawal and unfair discrimination, ostracization, and bullying, all of which are huge, huge issues for youth, experiencing these different symptoms and experiences. I think that this is an area that is really ripe for future exploration, really, is a new possibility, really, indicated by our findings. In terms of clinician support, the focus, again, it's really around symptom-related shame and discrimination that we're seeing the strongest correlates. And so, a concrete recommendation is that there are stigma interventions that could be utilized. And I've worked with Alicia Luckstead on her stigma intervention, ending self-stigma. We've actually adapted it to CHR. It's a group-based intervention, 8 sessions. It's, a pretty substantial lift in order to integrate into a program. So, my new way of thinking about this is that maybe we can take some principles from this unofficial stigma intervention and create clinical modules that can help address shame of symptoms. So CBT, cognitive restructuring around shame, discrimination based on symptoms, or coping strategies. And what you do is you basically help the youth to reinterpret, right, the way they're experiencing the symptoms, and then how people treat them, how do they respond. So it's basically helping them really to head off both the shame and the discrimination that's associated. A note here around the secrecy related to symptoms, and this is a very interesting, again, finding from the study. We'll have to see whether it holds up and other people replicate it. But the secrecy related to the symptoms actually looks like it's protective, at least, again, at initial identification. And so the timing of addressing secrecy should be done very carefully, and recommends do this through this concept of selective disclosure. You want the youth to help the youth find safe others, of course, that they can disclose to, and then the timing of that will be very, very important. Because again, secrecy related to symptoms appears to serve a protective effect. We don't want to take that away. My last note, of course, is to involve peers programmatically to help foster integration, to help, again, defend against symptom-related stigma. So lastly, of course, this work has been going on for a long time now. This is a list of probably an incomplete list of collaborators. I have bolded here the MPIs. At Harvard, it was Larry Simon, and then Chipster Kristen after Larry passed. Bill McFarland at Maine Medical Center. My other senior co-Is include Cheryl Corcoran, Bruce Link, Raghi Gurgis, and then there are a host of other folks, again, who contributed to either the R01 and or this presentation. I have a picture of Larry Simon. As you all know, Larry left us too soon. He is my dear friend and mentor, and I know he would be proud of us. I know he'd be proud of us bringing this work to the fore. And I know, I hope, Larry, that somewhere you are smiling down on us from heaven with us moving this work forward. So just one last slide, and I want to thank you very much and open it up for questions. Well, a question.
Yeah, thank you, Larry, for those fascinating findings. Larry will definitely be proud of you. So, yeah, let's see questions from the audience. I do see that there are some questions in the chat. I'm happy to read them out, but people could speak up if they want. So let me read them since you don't hear anyone speak yet. So Beverly Sullivan from Pennsylvania asks, I'd be interested to know if family members are more concerned about the stigma of labeling.
Oh, that's such a great question. What a great question. Unfortunately, we were not able to ask about this. It's a fantastic question, and I'm certain that some certainly would be. And my guess, well, actually, one of my students, Drew Blasco, who since got her PhD, did look at this very issue, and to see whether or not, whether youth with family members who had actually a family history of another mental illness, whether they experienced more or less stigma, and the answer to that is inconclusive, unfortunately. In some circumstances, it's more, in some circumstances, it's less.
Yep. We have just about a couple of minutes left. So, I'll bring up one other question by Ruth. Is symptom stigma defined as stigma associated with actual current symptoms, or stigma associated with symptoms of psychosis, whether or not they are currently experienced by the individual?
Great question. And keep my findings. So I showed you the items. It literally, the referent is about my symptoms and experiences. It was, we struggled with the wording of this, right? Because keep in mind our findings from before, we couldn't put the psychosis part in because not all the youth thought that they're at risk for psychosis, right? From precursor study A. So we had to keep it broader. So it really is sort of a catch-all. And I realize that's one of the limitations of the study. We don't know whether symptoms and experiences were, due to psychosis or otherwise. But I think it's fair to say it's attributable to the symptoms and experiences they were experiencing at the time, because all of them were asked in the present tense.
Yep. Yeah, I think we are at 1 o'clock at the moment. Is there any one question from the audience?
They're all muted, so they can't actually ask.
Yeah, but you can hear me, right?
Yeah.
So maybe I will ask one last question. And, this is in relation to this curious and fascinating findings that you have, that secrecy related stigma is protective. So that raises a question in my mind as to whether you see any relationship between stigma and delay in treatment, namely duration of untreated psychosis or untreated prodrome, whichever way you call it, and whether there is a difference in that untreated duration between symptom-related stigma and secrecy-related stigma. I'm sure you have the data to look at it, but you have looked at it.
Question, Cash. And it gets in. So I don't think, I'll have to double check this, get back to you. I don't think we actually have a good data on when the symptoms actually started prior to the identification. So we don't know how long they were, so to speak, in the in the rest of the real world before they came into the CHR service. Because that would be a fascinating issue. Exactly. Are they more?
Yeah, I have a hypothesis about that.
Mm-hmm.
The protective effect of secrecy related to stigma may be because some of these individuals may have enough of a ego defense system to be able to kind of compartmentalize the label and move on with the rest of their life, and therefore keep it secret, which actually is a strength, and that could reflect a protective effect.
Yeah,
in some way.
Exactly. And let me actually now I bounce it off of you as well, Cash. Let me your prior comment. Sometimes the youth can keep it secret and sometimes they can't. I wonder if because when it becomes more impairing, if they've been out of school, for instance, for a couple months or something, right? Hard to hide that. So it's quite maybe the secrecy could also be related to to their level of symptomatic impairment if they can hide it.
In other words, they may be less impaired if they are able to keep the secrecy.
Yes,
right.
Exactly, as opposed to more impaired. So that would be a really interesting issue for us to take a look at, the level of symptomatology.
Yeah, okay, yeah. All right. So thank you very much. This was a wonderful, very clinically relevant presentation for all of us. And I really appreciate your joining us today.
Thank you so much for your time. And
have a good rest of the day, all of you. Bye, everybody. Yeah, bye-bye now.
And thanks again.